I'm just going to talk a little bit about COVID-19. I think not much of this will be new to you, and then I'm just going to go through quickly a kind of protocol that we've got running on the ACCU, and then a checklist, so like a basic checklist for nursing staff and for staff who are sort of not used to working on critical care on a sort of regular basis, purely for COVID-19, because it does lend itself to kind of protocolized care. So a few core concepts related to COVID. So it's an RNA virus, positive RNA stranded virus, prone to change, to mutation. It's associated with direct cytopathy into the alveoli. It kind of attaches to the ACE enzyme in the alveolus, and so what you initially see is direct cytopathy in the alveolus without a lot of cytokine response, which is why you get a lot of patients who are relatively asymptomatic or might be presenting with a bit of a cough but not much else, and so it can take a while, 5 to 14 days on average, before patients become significantly symptomatic. The pneumonitis is associated with alveolar flooding, which gives rise to a degree of hypoxemia. It's also associated with small, thanks a lot. Cheers, thanks a lot. It's also associated with small bronchiolar collapse, which makes the ARDS picture you get with COVID-19 quite interesting, because the lungs are actually very compliant. They do tend to open up with CPAP, PEEP, recruitment maneuvers, proning. So that's kind of a good thing in many ways. Later on in the disease process, you start getting, some patients get a very severe cytokine storm, and so certainly the patient that we've had who's died, a lot of the patients in Italy, the younger patients who are dying because of this kind of very severe cytokine storm, this kind of host response that looks a little bit like a HLH kind of syndrome, so a hemophagocytic kind of syndrome, which has got very high mortality anyway. And we'll again, I think in terms of treatment of the virus and treatment of HLH, this is all evidence weak or evidence free. And so I'm not really going to talk much about it because I don't think there's much to talk about. But particularly for HLH, if in the small percentage of patients who perhaps do develop this, there are some things that we can use. But in general, most of our therapy is going to be supportive in nature. It's not really going to be giving Kaletra, antivirals, chloroquine, all these kind of things. They're untested and they haven't been recognised for therapy in this trust at the moment. Diagnostic criteria. So fairly standard, you'll know all these: persistent pyrexia, persistent cough, constitutional symptoms, classics. On labs, relatively nondescript. Something that's quite common in up to 80% of patients with normal white cell count is lymphopenia. Relatively mild rise in CRP, but transaminases seem to be elevated, and there seems to be an evidence of early cardiomyopathy or myositis with a troponin rise as well. On the chest X-ray, you tend to get bilateral ground glass appearances. Ultrasound is being used in the States, looking for sort of like B-lines, confluent B-lines. In China, they were using CT scanning initially. Everyone was getting CT scanning. We don't advocate that. We don't think it adds very much, and I think it puts more people at risk unnecessarily. The test that we're using is the PCR from either nasopharyngeal aspirates or better from sort of deep sputum. Only 75% sensitive, so as you're well aware, there are a lot of negative results, partly because of the quality of the aspirate. So poor quality aspirates will give poor quality results, and the best is probably secretions from the ET tube for post intubation. Again, avoid CT, also avoid bronchoalveolar lavage. Again, diagnostically, not much help. In the very small percentage of patients where you've got a big diagnostic conundrum, maybe, we've not seen that yet, but again, BAL and CT is effectively out. On the ward, for the deteriorating ward patients, we'd like these patients to be flagged to us early. We can put them on the board and then we can see how these patients are doing, how they respond to high flow nasal oxygen, how they respond to CPAP potentially. We don't advocate NIV. Parent team, now, a decision and a discussion with the family and the patient needs to be had, ideally by the parent team, before these patients get escalated, and so this needs to be clearly documented on CRS or in the notes. In terms of management on the ward, aiming for a negative daily balance, so we start frusenaling these patients relatively early. Something that they've been using in China and the States, which seems to be effective, is awake proning. So basically we just get the patients to lie on their front effectively, and that seems to improve a little bit. And high flow nasal oxygen CPAP delivered obviously in a side room. In terms of the framework, so this is dated today, and that's because actually the framework for discussions today is no different to the framework that we've used all the way through the last few years. That may change, but that will only change in terms of national guidance. So the framework that I use, and I think a lot of my colleagues do, is to frame it in terms of what are the chances of successful outcome? Okay, so if you're young, fit and healthy, then the chances of you coming through this well and getting a good quality of life back are high. But those chances go down with increasing age, with, as Lynn said, an increasing frailty score, increasing number of comorbidities. We'll know that diabetes, hypertension, heart failure, obesity, all associated with deaths in the elderly with COVID, and acute physiology as well. That's one thing, the chances of successful outcome. But the second thing to think of is the costs. So no treatment comes without costs, and critical care is the same. The costs of critical care are increasingly recognised as being quite significant in terms of weakness, debility, dependence, and the lower baseline you have, the worse these costs are. Deteriorating cognition, post-traumatic stress disorder and the like. So these are things that massively impact quality of life and need to be thought about by the family or the patients involved. If there's a decision made to escalate to critical care, to intubation, then again, at this time, this is probably the best time to speak about potential stop conditions. So again, so I very much view escalation as a trial. So if a patient gets intubated, then it's a trial of critical care to see whether critical care actually makes a difference to these patients. And so if there's increasing organ support requirements despite being intubated and ventilated, for example, then the chances of success go down even further. If it's clear that there's a prolonged period when the patient's not improving and someone who's got high frailty scores and high number of comorbidities, then again the cost to the individual increases because the likelihood of them developing dependency and severe weakness and debility increases. And then finally there's evidence of acute deterioration. So if they're going to cardiogenic shock, develop evidence of bowel ischemia or bowel infarction. And not now, but certainly if they've got severe CKD and then develop ARF, then again the Chinese data seems to show that 92% of these patients die. So again, this might well be a stop criterion in the future. In terms of the initial management on critical care, a couple of basic things. ET tube position, make sure that that's checked, and that's all the connections from the ET tube all the way to the ventilator is secure. Patient's got fine bore NG tube for feeding, and ideally a central line as well. Most of these patients are going to require low dose vasopressors at some point. On the nursing observation charts, we want to make sure that the following are clearly documented, that the patient's height is documented so that we can work out what the ideal body weight tidal volume is. So as you all know, the tidal volume that we use is related to the patient's size of the patient's lungs, and that's related to height rather than weight. So 4 to 6 mils ideal body weight per kilogram ideal body weight. And then the other thing is that we'll be aiming for neutral or negative fluid balance ideally. Baseline bloods. These would include a PCT because, again, there's evidence that PCT is relatively normal when if a patient just has coronavirus by itself, but if you get superadded secondary bacterial infection, then it starts to rise. And so a rise in PCT may be evidence that you've got nosocomial pneumonia on top, for example. ET secretions, and then we send clear for influenza, urinary antigens, all the usual things we would do for community-acquired pneumonia. On the drug chart, Most patients will get community-acquired pneumonia antibiotics, possibly Tamiflu as well if there's a high suspicion until we get the virology back, and furosemide, again, to aim for a neutral or negative fluid balance. Chloroquine is in brackets. Currently, there's not much evidence, and our drugs and therapeutics monitoring at the moment is going against using anything like this. And then we'll have conditions for escalation, particularly ventilatory escalation. So our PF ratio would be less than 20. So effectively, if they're getting much more than 40 to 60% oxygen, then that's when we start escalating to different forms of ventilatory assist, such as proning, recruitment manoeuvres, and the like. And we'll go on to that a little bit later. In terms of a daily checklist, this is a daily checklist on the protocol, and so it just goes through the systems in terms of airway, breathing, cardiovascular and fluid balance, care bundles, sedation, analgesia, and labs, and the things to kind of highlight on the labs. And what we've done is, I'm sorry, this doesn't really show very well, but basically we've changed this into a daily checklist, a two-sided checklist. So on the unit, every patient gets a four-sided daily sheet that is filled in. That goes through all the systems in detail and then goes through a plan, an impression, which the nursing staff and the physios and everyone else sort of fills in as well. It's 4 pages, it's quite in depth. That's kind of not really appropriate when we're dealing with so many patients. And as I mentioned before, COVID-19 really does lend itself to a protocolized kind of regimen. So the aim of this kind of daily sheet is to act as a checklist for some of the sort of basic things like the care bundle kind of things that should be done on a daily basis, or ensure that the nurse at the bedside does a daily basis, make sure that DVT prophylaxis is sorted, the patient's absorbing their feed, that we've got ulcer prophylaxis, and it's literally just a tick box just down the side here. There's some targets that need to be achieved, certain things that need to be documented on a daily basis. Check the ET tube length at the teeth, for example, make sure that that's not moved, NG tube length as well. Make sure that we've got a daily tidal volume target based on ideal body weight, so that we know that we're not going to give lung injurious ventilation and the like. Targets in terms of pH and PO2 and saturations. We don't want to hyperoxygenate these patients, so maybe 96-97% is fine, down to 90%, or PO2 of 8 kilopascals. There's a little ventilator bundle here that just goes through tidal volume and PEEP, and I'll come on to how we set those in the next page. And then there are escalation triggers. So for breathing, for example, if the FiO2 goes up more than 40%, we've got a little action plan, but the important thing is the triggers in red, who you call, ITU nurse, or if it's more than 60%, call the ITU consultant, or speak on the ITU ward round. Circulation and fluid balance. So again, if the noradrenaline requirement's going up above 0.3, then there's certain things we can do, like add hydrocortisone, and these things that often an ITU nurse who might be based in the Bay can manage. But if they're going up much more, then we've got to think about why that might be. Is there superadded infection? Could this patient be going into an HLH type syndrome? And so there's certain investigations that need to be sent off, and again, this would be for potentially an ITU consultant review, and so there are escalation triggers here. Sedation and analgesia, we're using the RATH score and the CPOT score for sedation and analgesia, and again, not perfect, totally admit, but I think it's kind of fit for purpose, and what we're looking for is competence, not excellence, to be honest, for trying to deal with so many patients. Sepsis markers again, so looking at white cell count, CRP, pyrexia, and if 2 of these 3 are going up, then start looking for an additional cause. Could it be a central line infection? Have they got a superadded pneumonia, or could something worse be going on? Drugs chart, there's standard things that should be prescribed, like DVT prophylaxis, ranitidine, antibiotics, that kind of stuff. So all fairly straightforward. And just make sure that we've got an escalation plan documented on CRS or in the notes. In terms of ventilation, in terms of setting tidal volume, the ventilators will have a height against tidal volume chart, but there's also a simple calculation you can use once you know the patient's height to work out what an ideal body weight tidal volume at 4 to 6 mils per kilo should be. We've got a PEEP chart here. There's a lot of discussion about high PEEP, low PEEP. High PEEP seems to be a benefit, and so for the sake of simplicity, we've gone towards a sort of a slightly higher PEEP regime here. But again, for discussion, if the patient's not doing well, we've got a RAS score, CPOT score, and then here what we have is trends. So for each of the systems, respiratory, cardiovascular, etc. And that's just a stimulus to look at the previous day's results or the last 2 days' results to see, are there subtle changes? You know, are we creeping up in terms of FiO2, noradrenaline, sepsis markers, to try and pick up a patient who might be deteriorating slowly, but that may not be obvious in a snapshot, you know, on the day. And then space for an impression and plan. In the event of deterioration, certain standard things to send off like PCT, ferritin and LDH, again thinking maybe is this HLH type syndrome. Chest x-ray, again the trigger for chest x-ray is set reasonably high. We don't want to be exposing radiographers unnecessarily to doing these kind of things, but again, if there's clear evidence of deterioration, if FiO2 is going up above 60%, then a chest x-ray may be warranted. ECG, again an echo. We're not echoing many of these patients, and it's only really if noradrenaline requirements going up a lot that we would think about getting an echo, and that would be a consultant to consultant discussion with the cardiologist. And then institute cardiac output monitoring, minimally invasive cardiac output monitoring. If there's hypoxemia, then options are to reprone, consider inverse ratio ventilation, a volume challenge. It may well be, if you've been running negative balance for a long time, that actually this may be a perfusion issue rather than a ventilation issue. And if the patient is appropriate, consider referral for ECMO. If the PCT is elevated, then look for nosocomial sepsis. Again, send off repeat sputum MCNS and maybe augment the antibiotics. Whereas if the ferritin and LDH are elevated, then this might be a high cytokine syndrome. And we have got, there is a license for using tocilizumab. We've not used it yet in this scenario, but it's something to consider. If there's hemodynamic instability, one thing might be that it might be related to the low pH. So we're aiming for permissive hypercapnia, low tidal volumes, and a relatively low pH. 7.2 is our target. If it starts dropping below that, then maybe giving a little bit of bicarbonate might help to stabilise the situation and start inotropes, adrenaline or dobutamine. And again, consideration for referral to ECMO. In terms of de-escalation, we've been caught out, so learned from our mistakes. So my mistake, actually, I should say. So 2 negative swabs I thought was okay, and so the patient got de-escalated, and then we found out that actually that those were negative. That was incorrect, and an ET tube sample came back positive. So what we suggest is that for de-escalation, as well as having 2 negative swabs, of which one of them should be from the ET secretions, that there should be a final decision made by a senior clinician, and if there's still a high clinical index for suspicion, the patient stays within a COVID bay. I think that's basically it. I think obviously look after ourselves. It's all the standard stuff: eat, sleep, downtime, look after each other. I think Tony Allnut sent out a really nice email a few weeks ago, and I think, sorry, a bit dry. Stay in the present, I think, helps. We're done.